All right, I think we're going to make a start. Oops, sorry, I should have stopped sharing before I start the slideshow. All right, good morning, everyone. Thank you for joining to today's webinar, which is the role of data in UNAIDS target setting and decision making. My name's Josh. I'm a PhD student at the University of Bristol, and I'm also a committee member of the INHSU Early and Mid-Career Special Interest Group. So we're recording this webinar, so just a bit of housekeeping. And I wanted to start by describing the EMCR a little bit. So the EMCR is a committee which is affiliated with INHSU, which is you all know, but it's the International Network on Health and Hepatitis and Substance Users. We're a global network of junior researchers whose work aims to improve the health of people who use drugs. We're mostly made up of early career researchers, so students and postdocs. And we have members from all over the world. So some people are joining today from Australia, or I'm currently in the UK with people in North America. And yeah, we do a lot of different types of events. So this webinar is an example of one. We're a really friendly group of people. So if you do plan on attending the INHSU conference in the future, it's good to join the committee, and then you have some people to chat to at the conference, so it's not so isolating. Yeah, so if you're interested in joining, we'll put some resources in the chat. And just to point out as well that it's free for PhD students to become an INHSU member, and it's also discounted if you're from a low and middle income country. But I don't know how much it costs if you're a postdoc, sorry, because I'm a student. Great, so our two speakers today are both from UNAIDS, which is one of the largest HIV organizations in the world. UNAIDS does a lot of work, I guess, at the programmatic level and the research and evaluation level. So among other things, UNAIDS does a lot of target setting. So many of the HIV targets that we work with all the time during our work was established by UNAIDS. Yeah, so I just want to introduce our two speakers before we start. So we've got Keith Sabin and Aline Louise Corenrump. Sorry, hopefully I pronounced those okay. So Keith is a senior advisor in epidemiology at UNAIDS. He's very experienced working with a lot of different groups from priority populations who experience increased risk of HIV. So that would include, some of the groups include people who inject drugs, but also men who have sex with men, transgender people, sex workers, and people who have been imprisoned. He's worked for more than 20 years in HIV at a variety of organizations. So I looked at his LinkedIn, and he's worked at, as well as UNAIDS, the CDC and the WHO. And in his role at UNAIDS, Keith uses epidemiological techniques to model the HIV epidemic and estimate incidence, prevalence, and ART coverage. So that's Keith. Then we've got Aline. So Aline is not presenting, but is around for some questions. She's a senior advisor in epidemiology and modeling at UNAIDS. She also has a wide range of experience in epidemiology, in particular with mathematical modeling, and has also got over 20 years experience working in HIV and other related diseases, such as STIs, malaria, tuberculosis, and mother and child health. Great, so that's kind of the introduction. Then I'm going to hand over to Keith, who's kindly agreed to give a short presentation on some of the work that he does with UNAIDS. And afterwards, we're going to have a Q&A, which Aline and Keith will both be a part of. But if you have any questions as Keith is presenting, please post them in the chat and we'll monitor them. So then once he's finished, we'll have an opportunity to ask him the questions. So yeah, please post in the chat as Keith is going. All right, that's it from me. I'm going to hand it to Keith now. Thank you, Keith.
Thanks, Josh. I see the screen, so I assume you're all seeing the screen. Very good. So I'm going to go over this process of target setting very briefly, the process, and then a little bit on how we go about that in terms of setting those targets. This is a process that we undertake every 5 years. and we're just finishing up or coming to the end of the targets that were set for 2025. Now, these targets were set around the year 2020. They go into effect in 2021, and we'll start trying to evaluate whether we actually achieve them in 2026 when we've completed the calendar year of 2025. This graphic shows the different clusters of targets that we have and the way in which those targets are distributed and in terms of success or lack of success. So anything that's green, which is really the section under HIV testing and treatment, those are the ones that we are either have achieved or are very close to achieving. And when we say achieving, we're talking on a country by country basis as well as globally. So, and certainly it has more impact when you think about it as a country target. So you can see in the red where we consider progress to be off track, which means we're just not getting close. We're not seeing great advancements. And then there are a few areas in gray where we have a lack of data. So we can't say one way or the other if we're making progress. Now, all of this has been revisited yet again as we're setting targets for 2030. Several years ago, UNAIDS and the global community really decided that we were going to end HIV as a public health threat by 2030. So the targets that we're setting for 2030 have that in mind. And as part of that process, can I ask, can you see the blue box, or is it hidden by pictures if I have them on my screen? Let me put that away. All right. So we convened a group of experts that come from all phases of society to recommend these targets. And the targets should be evidence informed. And ideally, they should be measurable, but they should also be ambitious because we really do want to get to the point where HIV is not a public health threat any longer. Now, we have this list of characteristics for the targets that we would really like to see applied. So they balanced across representing different communities and different approaches to those communities. They should show impact. They should have evidence underlying them. They should be easily communicated. They should be human rights based and gender transformative, moving towards gender equality. And above all, as an M&E person, they should be measurable. You may recognize some names on these lists, but these are the people who are sitting on the advisory group informing the targets for 2030. And the overall vision here is to set up a task team, develop the targets, create a roadmap that we're calling sustainability roadmaps, because ideally countries will be able to take on this work using their own budgets and their own revenues and not rely so heavily on donors and other bilateral partnerships to get towards these, to approach these targets. And all of this is really probably subsumed by a strategy that is designed to use these roadmaps to achieve these targets. So the targets are what we want to achieve, while the strategy describes how we will achieve those targets. So that is reiterated here. We're going to continue with the current strategy through its end, which is in 2026, which is when we will be evaluating the 2025 targets. And as we move forward, we're trying to reduce the number of targets that are being used. And so we're going through this and looking at whether the targets actually have relevance to country program managers. It's very easy for us sitting in a place like Geneva, or perhaps in an ivory tower somewhere in academia, to come up with targets that really speak to us intellectually or politically. They grab our senses and take hold. But for somebody who's trying to manage their country's program with the resources that are available and the political reality that they're confronting, some of these targets really don't apply to them, and they don't see how they apply to them. And so they're ignored by those places. And so that's something we're trying to take into greater account while not losing sight that some communities may be overlooked if we solely rely on country program managers. So that's some of the balance that we need to do. And ideally, we're also going to link to other strategies within the wider UN system, such as universal health care, and try to ensure that we're fitting the AIDS response, the HIV response, into the wider global goals for both health and development. And in some cases, even if a target is not immediately measurable, sometimes we have to have a target just to create strong political will and also to be ethical and lean towards social justice, but we still need a scientific justification as well. So all of this is coming into balance as we work on these targets. Now, how do we come to these targets and what underlies this? We tend to rely not recently, but for several rounds of these target setting on the goals model. Now, the goals model is developed by Avenir Health, which there's a link here, and everything about goals is on their website. The goals model is a part of the spectrum modeling platform. And it allows you to ask these questions. What is the impact of scaling up prevention and treatment programs? How much money is this going to cost to get to our goals? What if we reallocate the funding in different ways, different patterns? And what can we achieve with the money that we currently have available? As I said, this goal sits in the spectrum package of models, and it's freeware, so you can download it. If you've never looked at it, please do have a look on the Avenir Health website. Now, the basic model within goals is using the spectrum model. So goals is taking the spectrum models that UNAIDS is developing in collaboration with, we developed them with about 170 countries globally. And goals sits on top of those results. And in using those results, you can see here, just very briefly, the inputs to that model on the left in the beige, the demographic data, program statistics such as ART and PMTCT coverage, epidemic patterns, whether it's a generalized style epidemic or a concentrated among subpopulations epidemic, and then in some instances, we include behavioral data. And that goes into these models that are circled in red, all of which sit within the Spectrum platform. And those models create an incidence estimate, and the incidence estimate runs through the AIM model, which yields these results in terms of mother-to-child transmission, child results in terms of pediatric HIV, and then adult results in terms of numbers of infections, number of new infections, AIDS deaths, and need and uptake of ART. So that's all very quick, but again, this is all readily available for you to explore on the Avenir website. And we also have tools if you want to self-study on this. Now, the goals model is somewhat different, but overlaps. So we talked about here we have different population groups that one can use. So we have different population groups that can be used. Oops, sorry, lost my share. Apologies for that.
Is the share button?
No, I'm getting the share button.
Working.
It just wasn't showing me the slide set again. Now it's there.
Ah, perfect.
There we go.
Okay, I just re-added you
All
as
right.
a host in case.
Yeah, now I'm good. Well, sort of good. So here we have the population groups that are present in the standard goals model. What's different from the models that we use routinely is that there's a behavioral component. So we add in numbers of partners, number of sex partners. We add in condom use. We add in the age at first sexual intercourse and also needle sharing behaviors. So we have the different sorts of transmission that include probabilities of transmission. And all of this leads to a model that yields new infections. Sorry. And then down at the bottom of the screen, we can see the different programs that can impact on behaviors and probabilities of transmission. That's reflected by these blue arrows here. So the national program might have policies that will impact on the availability of ART, for example. We might have programmatic enablers that will impact on the availability of condoms, for example. So all of this feeds into the goals model. All of these require data that are collected primarily through surveys, occasionally through programs. Now, goals transmission risks have different scenarios, and we see that we have a low risk adults may be at risk, but only if their partner is at higher risk, right? So a low risk individual is very unlikely to interact with another low risk individual and put themselves at risk for acquiring HIV. So there are all of these networks and crossing probabilities of transmission between different groups. And these probabilities are all incorporated into the way goals structures transmission. These are all based on published surveys that are reviewed periodically usually by the UNAIDS reference group on modeling, but also individually by Avenir as they will update their goals model parameters. And so you can see here just examples of forest plots for the reduction in non-use of condoms among sex workers, and what does that do in terms of how do we apply these assumptions. Similarly, we have the same question for men who have sex with men on the right. So if we have behavior change that we incorporate into the model that leads to greater use of condoms, then we can incorporate that into the model to show what the potential impact of such a behavior change intervention might be. Now, goals then fits epidemic outcomes to survey prevalence data first. This is very similar to what we use in Spectrum in terms of the AIM model or the EPP model, estimates and projections package model. And they rely on different survey and surveillance data. Those data can come from household surveys, they can come from bio-behavioural surveys and other sources. And they will use as much data as are available. And sometimes that's a bit of a challenge, data availability. Now, after those models, those initial models are applied, then we come in with these different scenarios that can be created within the goals model. So here, you can see the blue line under new infections on the left. That's the baseline. If we change nothing from today, in this case, from 2015, this is what we expect new infections to do over time, right? We'll see a steady increase. If we take standard implementation of projects, which is this mustard yellow line, we see this kind of decrease in new infections. If we take what is implemented or called for in the National Strategic Plan, we get this gray line, which shows a greater decrease in new infections from the standard implementation. And then if you do something that we called Fast Track, which was this initiative that came out of UNAIDS to really put in heavy emphasis and focus on certain elements of interventions to fast track the results, and we get this orange line at the bottom of the figure. And the same interventions applied. Also, we have AIDS deaths outcomes. And so you can see the relative benefits of the different targets or the different scenarios in terms of what we are implementing and trying to achieve with those different scenarios. On top of all this, goals will take unit costs to deliver any given service to a single person. And so whether that's the unit cost for reaching a single sex worker or a person who injects drugs, or engaging with a boy or a man for voluntary medical male circumcision or male medical circumcision, per person year of treatment, all of these costs are aggregated and put into this kind of box and whiskers plot that will allow us to cost out interventions in different scenarios and then apply that cost to what each scenario is going to set back the Ministry of Finance or the donor. So we can look at the resources required by scenario. So here you can see the baseline resources required is almost nothing changes. It's probably the cost of inflation here. But we also see that the value added for Fast Track, not value added, but the increased cost of Fast Track is relatively minimal when you compare it to the National Strategic Plan. But it is slightly greater when you take it out to 2030. But this, you can imagine, is a very useful tool for the people who are trying to make decisions within the Ministry of Finance, the Ministry of Health, and in the AIDS response more generally. The software will also provide the resources required for each intervention. So here we can see the distribution of interventions in 2015, and a lot of that money, that orange, is ART. So ART is or has been very expensive even as the price comes down. But as we put more and more people on treatment, that price tends to rise. And to some degree, the increased numbers of treatment are offset by the reduced prices of treatment. But some of the other elements you can see are steady state over time, but it gives you a sense if we change the scenarios and we change the mix of interventions, we can see what resources are needed for that. And within goals, there is a cost effectiveness analysis tool that allows us to look at the number of infections averted according to the model and what the cost per infection averted comes out to be. And you can generate these tables and these plots using this tool. There's also a way to allocate those sources and optimize the resources that you have available. And this tool allows you to do exactly that. So you could take the minimum and maximum for different interventions in terms of cost, put it into years, and then get a sense of what would happen if we optimized costs versus the way costs are currently distributed. still trying to achieve the decline in new infections that we would like. So all of this feeds into a single tool. Now, some of the challenges we have is that some programs are costed, but they don't have a direct impact. And that can be very challenging to incorporate. So we know, for example, that mass media has an impact on behaviors, but how the cost of mass media can be related and what it is, that might be easy to cost because it's an ad buy, but not all mass media is as clear, especially as we move into social media. Social protection costs tend to be costed because we tend to view that as cash transfers or things of that nature. But human rights programs are much more difficult to cost. How do you cost assuring the human rights of individuals and certain policies being in place to protect the rights of groups and individuals? So having these costs and putting that all together is one of the challenges. I don't know how many of you might be economists, but that's something to think about for future endeavors. Now, all of this is a lot of this work is published, and you can look up the articles. But just to focus in on this, because we're really here to talk about injection drug use and people who inject. So just to reference some of the results that we put out last year, where we talked about new infections among key populations and their partners over a period of time. Those results are drawn out of the goals and AEM, which is another model similar to goals, but it's standalone or can be incorporated into Spectrum. But it gives very similar outputs to goals, but it's only used in 13 countries in Asia. So it's a very limited use case that we have for that. But these results informed this paper that we have in the graphic, and you can see some of the results that came out of that well, this is the distribution by region, but we had a similar distribution of new infections among the different key populations. What we're changing or have already begun to change is to put in an age-sex model into Spectrum that will also flow into goals, and that will allow us to look at, for example, adolescent girls and young women and programs that are designed for that population. Some of this will allow us to get a better handle on the aging of HIV epidemics and of the people living with HIV. And so this is has been a long-term goal, and we're actually very close to having this model. It is in place for sub-Saharan Africa and will become increasingly used in other parts of the world as the data become available. So, and it incorporates all of these packages so we can look at the effects of PrEP as well, which is a relatively new addition to both Spectrum and the goals model. This is just more on that. And then just to say that, one of the advantages, and we view it as an advantage, it might be a disadvantage, is that we have traditionally relied on this thing called the estimates of projections package, which is an element of Spectrum to get data on key populations. And so this is an example from a South American country. And you can see where we have slight differences between the EPP model using these surveillance data and the goals model, which just shows a different peak, but in both cases for men who have sex with men and female sex workers, but they end around the same place. So some of the historical weighting might be different. What we don't have from this country is any data on people who inject drugs. But goals has the ability to make certain assumptions and still produce a model that, using these regional assumptions, we can come up with a rough estimate for a population that is being either ignored willfully or they don't see the need because the population is so small but we can say, look, you may not have much of a population, but we have this suggestion from the model that you might need to look at people who inject drugs in your setting. And maybe they come back with nothing, maybe they come back with something, but it's something to spur reactions from countries. And so that's it for my slides, and I'll stop there and turn it back to Josh as our moderator.
Josh, do you want me to pick from there?
Hi, yeah, sorry.
Yeah.
I should have mentioned earlier that my co-host is Kennedy. So I think Kennedy's gonna ask the first question. I don't think there's been any questions in the chat, but we did anticipate that some people might be a bit shy. So we've come up with some of our own questions. So yeah, Kennedy, you can take it.
Thanks, Josh, and thanks so much, Keith, for that fascinating, powerfully delivered presentation. It's always a pleasure to listen to your presentations. That was great. And not only great, but I think it really gives us a lot in terms of our understanding of the work that UNAIDS alongside its partners are doing. And so, the aspect of what in terms of the targets, the aspect of how in terms of the strategy, looking into the tools that are being used by UNAIDS, like the goals that are being used at the country level, and looking at all that rich data. I think for me, it's been great. So I would encourage people, if you have a question, kindly put it in the chat box. But even most importantly, we'd encourage people to just ask questions. And before I come, I think I'll give Adelina seems to have a question. So I'll still ask my question, but Adelina, go ahead.
Thanks, Kennedy, and thanks, Keith. That was a really fantastic presentation. I was just curious because I do mostly work in measuring incidents in the hepatitis field, and there's a big emphasis on empirically measured incidents, especially for countries to actually be validated for having achieved the targets. Is there any, it seems like you're using the goals model, and modeled estimates are being used to evaluate progress for HIV incidents. Are there any sort of specific targets to measure incidents in these populations, or will modeled estimates be accepted? Or, I'm just curious what the discussions around that have been. Thank you.
All right. No, it's an interesting question, and it's something that comes up occasionally, depending on the country. Because spectrum estimates are generated by countries, by national programs, the data that go into those and the data that come out of those are perceived by those countries as owned by those countries. And they consider that their representation in this domain. So when we bring in external researchers and their work, it's less acceptable to them unless there's just an absence of data from other sources. Some countries are adamant to the point that they won't even incorporate as inputs data from academics because it's not data that the government collects. So some governments do enough data collection where they have that luxury to say, I don't care what University X has found. Our programmatic data say something else. And so that's the challenge. I think for us, the value in work such as yours is to triangulate with our results and to say, what is Adelina doing? What are her results and her team's results looking like? And have they done something different that improves what we're doing that can be incorporated? And that's the sort of circumstance where we'd say, if we see something, we're going to invite you to one of the reference group meetings and say, is this something we can adopt or adapt into what we're doing? Because for UNAIDS, at least, as a UN body, we're really obliged to meet the needs of the member states before anything else. So it's one of our limitations. It's also one of our strengths.
Yeah. I agree with your point about triangulating. That's great. Thank you.
Great. I think we still welcome any questions. Please feel free to raise your hand or type it in the chat. We'll be able to capture that. So I think my question to you, Keith, is when you use estimates to inform target setting, particularly for global perspective, do you usually use data from published literature, or do you use an in-house analysis, or a mix, a combination of both?
Yeah, make sure my mic is on. Yeah, depending what we're publishing, when we publish in the Global AIDS Update or what we put on AIDS Info as official data, those data are drawn from multiple sources. So it really depends on where in the model we're talking about. So there's a particular Asian country who, as I said, as I was alluding to earlier, they won't use data that are just published from a journal. Even if it's Indian authors or Chinese authors or Kazakh authors, that doesn't matter to them, right? The authors are not government workers. They're not, so those data aren't official. They don't want those as inputs. Other countries where they either lack those data or they'll take anything that is reasonably strong and usable in the context of what we need to inform the estimates, and those go in. So it will vary by context. What's different here is historically, Spectrum has been country approved. We only publish results from Spectrum result data if the country says you can publish it. We'll use it behind the scenes, but we won't publish it. The data from goals, the goals models themselves are not national country approved results. They're built in many cases on country approved Spectrum results. So the data that are used as inputs or inform the assumptions in goals to this day are pulled from the literature, from systematic reviews or other types of resources, depending if it's an assumption or an input that we require that's specific to a country, or just we need a regional input for an assumption about the rate of mortality by age and sex, for example. That might be a synthesis. So those data will use published reports because very often that's not coming from any national government source. And we need those kinds of data. And so the countries might back off on that. But like I said, those are not nationally approved results in goals. That process is changing. We're trying to move to a process where goals data are included in the overall process of national approval. Maybe that's a can of worms we should not open, but we're here to serve the countries as much as anything. So, that's going to be the process moving forward.
Thanks, Keith. And I think, part of avenues in terms of collaboration between the INHSU EMCR network with UNAIDS, I think in terms of feeding into some of the data gaps, you did allude earlier that sometimes you'd have the reference group asking the UNAIDS reference group asking some teams to either feed into some data gaps through systematic reviews. So those are some of the avenues that, we can collaborate as INHSU EMCR. And I think those are areas people can be watching out. Josh?
Yeah, thank you, Keith. It's really interesting. I guess I hadn't really thought about when it comes to making decisions about data and where data should be sourced from, how much that decision-making process is in the hands of the countries. I guess I'd always assumed that it was like UNAIDS were making decisions about the data and where it's coming from. But it sounds like it's sort of like you have to work quite closely with the countries themselves when you're making these decisions. And I'm wondering where EMCRs, I guess, can be part of this process, you know, like when you're talking about stuff like impacts on risk behaviors, surely the best place to get that information is from published literature. I mean, correct me if I'm wrong. I guess it's not really a question.
Yeah, I think I hear what you're saying, where it's going in any case. Yeah, I think there are two issues there. One is we do work closely with countries to do some sort of quality assurance on the data that are coming in. It's more challenging when it's national program data. Yeah, countries will tell us our ART data system is perfect. And, but then they have 120% ART coverage. So something's not right. Right. So, either the model's wrong, the ART numbers are wrong, or, you name it. I think where there is an opening for EMCR, especially when we're talking about people who inject drugs, is in the direction that we're moving. But countries such as Kenya, for example, they have data. They may not have sufficient data for what we need, but as we're moving to a new style of model, Kenya has not traditionally, from our previous modeling exercises, they didn't need data from key populations. They used ANC, pregnant women data, and they used household survey data. And the feeling was, well, if there are people who inject, they're somewhere in the household surveys, or they're pregnant women who injected or are partners of injectors. So somehow they're reflected in the total numbers. But now we want to look at people who inject and have discrete interventions that are informed by this modeling process. So a country like Kenya has the luxury of having collected data over a period of time and can fill in the inputs required for the goals model. There are many countries that do not have that luxury. And so I think we can start looking at the countries where those gaps exist, so we can't inform their goals models of the near future with data. So how do we make up for that gap? EMCR, early career, ECMR. That's where we can find people to look for those data. We also need the synthesis reviews to fix the assumptions, because we know, for example, that life expectancy of people injecting drugs tends to be shorter as a population than the rest of male or female, right? We have a parameter for that, which we last updated probably 10 years ago. But that needs to be improved and extended by region, perhaps, right? So can we do that in a coherent way? That's a systematic review waiting to happen that would inform the kind of work we would really be anxious to use, as one example.
Yeah, I guess because like looking from the outside in, it's hard to know where the gaps are, because the data that we see is usually the best data, because that's the data that gets distributed. So I mean, it's really difficult to look, especially when we're looking over like many dozens of countries, and see where the gaps are as EMCRs.
I think that's something we could help with, and I think between Aline and I and a wider team that we have available, we don't have a big team, but we have more people than the two of us, and we can look for within the modeling after this year is done, because we're just starting the workshops now, so we're just starting the modeling process. But by June, we'll have an idea. Maybe that's something that somebody could come in and work with us to go through the data that were used to inform the 2025 round and say, what's missing? Which countries didn't report X, Y, or Z inputs, or had to use assumptions that were drawn from a completely different region that is unlikely to reflect the realities of that country's region. So that's something we could bring people in to help do, and guide that process so that we can start filling in those gaps. First, we have to identify the gaps. I mean, we may think of a few off the top of our heads, but I can't speak for Aline, but I haven't looked at it systematically. For us, this process is too new.
And I guess that leads into, do you know of any opportunities for EMCRs to maybe, are there internships or opportunities for EMCRs to collaborate with UNAIDS?
We do have an internship.
I'll put you on the spot a little bit, sorry.
No, it's fine. There is an internship with UNAIDS. It's paid. I'm not sure it's a living wage. We don't cover airfare or housing, but it's just, you can live on it in Geneva if you have a few other resources. So that, it's a minimum, what is it, 6-week commitment is the minimum, a 4-week commitment is the minimum, and up to 6 months. So yes, that's available, and we would strongly encourage applicants for that. You have to be recently out of school, so it's really for early career more than mid-career. You have to be within, I think, a year of graduation, or you can be not graduated yet. You could be not finished yet, also, but it's not a mid-career thing. But yeah, in terms of resources, we don't put out a lot of grant opportunities. They come up sporadically, usually because somebody else gave us money. So the work we were doing with some of you, with Peter Bickerman, that was some funding that we came into for a discrete need that we had, but we don't, we're less of a donor than we are a donor recipient in reality.
Well, maybe we'll share the link to the internship when we distribute the recording as well, if that's okay.
Yeah.
I realize that we haven't given Helene an opportunity to answer questions or contribute. I'm not sure if there's anything you wanted to add, Helene.
Thanks, Josh and Keith. No, nothing to add. Listening, that's yes, we got the overview and the questions all right.
Okay.
I will mention that Aline is the queen of triangulation and loves doing that kind of thing. So if you want to come with some ideas and proposals, we might not get to look at it until June, but I think there's some opportunities there that we would probably be happy to explore. How much support we can offer is, there's a new government coming in with our major donor, as many of you may be aware. So January 20th, we don't know what's going to be our financial situation.
It's scary to think about. I think that's all the questions I had written down. I had some slightly more technical questions, but I don't want to go too far into the weeds about the model itself. Kennedy, did you
That's why Aline's here.
Yeah, no,
Yeah,
sure. But
true.
as Keith says, we very
for the
much
weed.
welcome all triangulations, and no model is perfect. They're all simplifications, and every triangulation teaches us something on where the uncertainties are, or where we're most uncertain, or if everything is consistent and so quite plausible. Yes, so and some countries are picking this up as well. They routinely triangulate several models already. For others, we do it or we help them. That includes the standard free software models we have available, Spectrum, with several options, and the goals model also in Spectrum. Few others like Optima, an external model, but special models calibrated for a few countries or even one, it's always useful. Yeah.
I think especially around individual populations, because we're estimating incidence for people who inject in using goals or AEM or even EPP. But those might not be informed by as much data as, say, Adelina's model might be using. So I think that's really intriguing to us. It's discrete, but it's still incredibly useful because we have to take this bigger picture look. But if we're wrong on people who inject, that's an inequity we need to solve. So
I don't think there's a model in the world that uses more data sources than Adelina's. So that's yeah. So the inclusion of these the behaviors, so that's relatively new. This the impression I got from the presentation. How much uncertainty are they contributing when you start adding them in?
I think it depends how much which ones we're talking about. But
I suppose, and how much uncertainty in the
I have not
behaviors themselves
used goals yet, which Aline has. So I don't know did they ask for an uncertainty parameter on the behavioral interventions?
Not as inputs to goals or anything. It's not inputted. There is uncertainty on outputs, which for most is mostly driven by the parameters, like the biomedical ones that apply across all subpopulations. I don't think the uncertainty is made bigger like for drug users than for other risk groups or low risk groups in goals. No. In a way, the uncertainty outputs from models are symbolic. They're, I think, typically minimum estimates of the real uncertainty. But even so, that's much better than not articulating the uncertainty at all. Yeah.
So treat them as notional.
Yeah, and lastly, any triangulations when we think of drug users will be especially useful for the many countries where the overall national epidemic is estimated based on just national case notifications and death notifications, and where there's no distinction into subgroups at all, apart from men and women. That applies for many concentrated epidemics and especially the high-income countries, or the countries in Eastern Europe, for example, and Central Asia, but also several in the Middle East.
Yeah, that's a huge gap.
Interesting. All right. Getting quite close to 12 o'clock. Kennedy, did you have any final questions?
Maybe before, just one final question is just to say to colleagues who've been able to join, as well as those who would be watching this at some point later, is we'd appreciate if you're able to join our SIG network, but also to say there's an upcoming conference for the INHSU 2025, which will be held in Cape Town. So people should be on the lookout to put up some abstracts on that. My last question to Keith and Eileen is, with the target setting, and apologies if I may have missed that earlier on, at what point, do the countries come in terms of their contribution and for purposes of buy-in? So at what point are countries involved in the target setting process? But also tied to that is, from your experience working with countries, there are some countries, for instance, my experience in Kenya is they have a strong team around target setting, around strategic information for HIV and STIs. So are there other countries where, EMCRs within our network can be able to link into those teams and to be able to see how best they can contribute even at the country level?
That's an interesting question. I'm not sure I have a satisfactory answer. what's changing this year is the fact that goals is moving towards country ownership, which means the countries will see what they need to do to achieve those targets or to set their own targets. Previously, the target might be something like 3 million people on PrEP, and that's a global target. Then countries were saying, well, what's my contribution? How much does my country need to go towards that? Well, we had that because it was all built out of goals, but it was never something that was put on paper and distributed and say, this is what we think your contribution needs to be. So it was left to the countries to decide, one, are they going to create a national target to move towards that global 3 million, or are they going to ignore it and just say, we're going to do the best we can without a formal target? And so different countries treat it differently. I think Kenya is probably one of the leaders in something like this. I imagine, but don't know for a fact, that a country like South Africa, with its data-heavy environment and evidence-based inclination, they may do something like that. But I think that's something we could find out. I just don't know the answer offhand if there are groups that A, exist, and B, are open to a young academic joining to either learn or contribute. But that's something we could ask about. I think it's a valuable activity, but I just don't know where they're at in terms of that. I mean, we know that if goals is going to be adopted, that's part of the spectrum workshops that have already begun occurring. And those teams are usually finite in the workshops and then expand greatly when they get home. And it's a much broader team. And so Kenya, when I participated in some of those, 15 years ago, it was a big room full of people from across the country. So, it's a very open process. Other countries, much less so, if they do it at all. So, but it's worth exploring.
Thank you.
Thank you. Okay, we have 1 minute left, so I suppose I'll end by saying thank you so much to Keith and Aline for joining. And Keith, thank you so much for preparing those slides and presenting. We really appreciate it. And yeah, that's it really. Thank you to all the people who joined as well. And thank you to Kennedy for co-hosting. And I think I'll call the webinar closed there. Say goodbye.
Okay. Thanks, Josh. Thanks everybody for listening to me babble. All right.